Okay, good morning everybody. Today we are going to learn about the treatment of psychoneuroses. So what are the various types of treatments available in psychiatry? So an overview of today's lecture. First we'll learn about the history, classification, drug selection, that is what are the various drug factors, safety, what are the patient related factors which help us in drug selection, then the dosing duration monitoring, the treatment outcomes, then the classes of drugs, and not just drugs, we have a lot of other methods also. So brain stimulation methods, surgeries, vaccines, what are the alternative medicines also, all these things we'll be discussing. So from a history point of view, for centuries plant extracts and natural substances were used as mood and anxiety influences, and also for sleep. For example, if you look at alcohol, tea, coffee, all this does influence your mood and your sleep. Then opium preparation, bromides and hallucinogens were used. From the 1930s to the 1950s, the most effective biological treatment was electroconvulsive therapy, the shock therapy, which is colloquially known. Antimanic properties of lithium was then discovered in 1949. Then came chlorpromazine. So chlorpromazine was the first antipsychotic to be discovered. Then coming to antidepressants, iproniazid, it's a MAO inhibitor. We don't use these now. It was being developed in the treatment of tuberculosis, but because it improved the mood, then we found that it's an antidepressant and it's used as an antidepressant. 1957, benzodiazepines were discovered. So first of them was chlordiazepoxide. 1958, butyrophenones, and in that we have haloperidol. So haloperidol is the first generation antipsychotic. In 1950s, then risperidone was discovered, which was a second generation antipsychotic. So when we want to classify or categorize the drugs which are available for treatment of psychiatric patients, we can grossly classify it into antipsychotic drugs. They're also known as neuroleptics, antidepressants, mood stabilizers, then anti-anxiety medication, hypnotics which are used for sleep, and psychostimulants. Okay, but problem with this classification is it's not diagnosis specific. We have multiple therapeutic rules, so each drug will have multiple indications. It is not officially recognized as a psychotropic agent. So drugs like propranolol, clonidine, verapamil, pregabalin, these are not even psychotropic drugs, but we use them in the treatment of psychiatric patients. So as a result, reclassification of psychiatric drugs is being done if they are classified according to mechanism of action, then it's a better way of classification rather than by indication. So if we want to classify it as based on mechanism of action, then we can classify it as an enzyme inhibitor, enzyme modulator, ion channel blocker, neurotransmitter releaser, positive allosteric modulator, receptor agonist, receptor antagonist, receptor partial agonist, and a reuptake inhibitor. So all these you'll be seeing in the subsequent slides, but these are the modes of actions that can be possible by a drug. Now drug selection. So when to give what drug? It depends upon the drug factors, safety profiles, and patient related factors. So drug selection. Drug selection based on the drug factors. Uh, so coming to the pharmacodynamics. So major pharmacodynamic consideration which you should take when we want to give drugs is the receptor mechanisms, the dose response curve, the therapeutic index, the development of tolerance, dependence, and withdrawal phenomena, and the clinical response to the drug, that is any adverse effects or side effects. So this is what you will be learning in pharmacology, especially MBBS. Medo, you'll be discussing this in pharma in very detail, but we'll just go over the drug in a very superficial way. Okay, now drug factors of pharmacokinetics. It helps us in predicting the onset and duration of drug activity, the interaction between the drugs that alter their absorption, distribution, metabolism, and excretion. So this is what comes under pharmacokinetics. And each and every drug has a different pharmacokinetic property. So when we know that particular property, then we can decide or select that drug accordingly. Now, what are the patient related factors? Patient related factor one is response to medication. So, every patient responds to medication in a different way. So, it's not like same patient will respond the same way to the same antidepressant. Sometimes some patients are sensitive to side effects. So some patients will develop side effects very quickly. So this is a patient factor again. Then depending upon the diagnosis, also the genetic factors, then lifestyle. So is the patient having a sedentary lifestyle, or is the patient active? Is the patient taking other medications? Does the patient have other disorders like diabetes, hypertension, hypothyroidism? Then past history of drug response. Sometimes patient's attitude is also important. It helps in deciding the aversion to certain type of side effects. Like some patients immediately after taking the medicines will feel GI side effects, and even if they are not a lot, patient might feel that I'm having gastric discomfort, I won't be able to take this medication. And sometimes preference for a specific agent also needs to be considered. A lot of times patients google and come, and they have their own preconceptions about the medicines, so this should also be kept in mind. Patients family history of drug response is important, because if a family member has responded to a particular way to a particular drug, it is possible that that patient will also respond that way. Again, it comes to genetics, sometimes environmental factors also. Now, dosing, duration, and monitoring. So dosing depends upon the inherent sensitivity, the ability to metabolize concurrent medical disorders like again diabetes, hypertension, concurrent medication treatments, and history of exposure to previous medication. Duration is again different for different disorders. So drugs must be used in effective doses for a sufficient period. So this effective dose and sufficient period is different for different disorders, but it's usually for a long period of time in psychiatry. Compared to other medical, or if you're giving antibiotics, it's just for 5 days, but psychiatric medications usually go for a few weeks or months probably. Time of dosing is usually based on the plasma half-life of the drug. So if it has a short half-life, then we have to give it multiple times. If it has a long half-life, if the half-life is for 24 hours, then you can give it just once a day also, and that will be enough. Now, treatment is broken down into three phases. So, irrespective of diagnosis, most of the treatment is the initial therapeutic trial, then continuation, and then the maintenance phase. So, these are the three phases. And treatment outcome is usually decided upon the disorder again. So goal of the psychotropic treatment is to eliminate all manifestations of the disorder. If a patient is coming to you with depression, so all symptoms of depression should go away. The degree of improvement below the syndromal threshold is defined as remission. So the definition of remission is that improvement should be there of all symptoms at least. Patients who improve but do not experience a full resolution are considered to be responders. So responders means partial response is there. Relapse means that the patient was taking medication, improved, but then stopped medication. Recurrence is again reappearance of the symptom. Treatment failure. So what do you do if the patient is not responding or patient is showing no improvement? First, is the diagnosis correct? Does the patient have hypothyroidism or does the patient have depression? Both these diagnoses have a lot of symptoms which overlap. So was the diagnosis correct? Second, are the observed symptoms related to the original disorder or are they actually adverse effects of the drug treatment? A lot of times side effects and symptoms of the disorders can also overlap. So akinesia, which resembles psychotic withdrawal, and a neuroleptic malignant syndrome, which has fever. So long-term use of SSRIs can produce emotional blunting. But emotional blunting is also seen in depression. So is it part of depression? Is it part of the side effect? That deciding is based on the clinical skills of the doctor. Now again, treatment failure can also be due to intolerance of side effects. So patient is not able to tolerate the side effects. So before the effect could come, patient stops treatment. Third was the drug administered at an appropriate dose at a sufficient time. So this is important because antipsychotics or psychiatry medications, we start at very small dose. Sometimes patient may need higher dose, patient may need for a longer time. Fourth, did a pharmacokinetic or dynamic interaction reduce the efficacy? And fifth, did the patient take the drug as directed? So patient is supposed to take the drug daily. If the patient is taking an alternate day or once in 3 days, again, this might lead to treatment failure. So what is drug non-compliance? Non-compliance means the patient stops taking drug. It can be due to adverse effects. It can be due to poor patient education. We did not explain the patient how to take and how long to take. Sometimes patients just discontinue because they feel that they have recovered. But sometimes the underlying depression or psychotic symptoms are still there, but patient feels that I have just recovered, so I don't need it, and they discontinue the medication. Another uh, terminology which you will see in psychiatry and in all other fields also is treatment resistance. So some patients fail to respond to repeated trials of medication. Not a single factor can explain the ineffectiveness of various interventions in these cases. Strategies which we use are switching to some other medication, using drug combination, giving high doses of therapy, or giving it for a long period of time, at least for 2 months. Thus, it may take 8 months to declare a patient as treatment resistant. So, don't be in a hurry to call a patient as treatment resistant. Give the drugs for a appropriate dose and an appropriate time. Now comes tolerance. So, tolerance is defined as a need to increase the dose of a drug to maintain a clinical effect. This phenomena is used as a basis for starting some drugs at subtherapeutic doses with a plan to adjust the schedule once the patient can tolerate higher doses. So this is the phenomena of tolerance. Now what is withdrawal? This is very important, specifically in psychiatry. Withdrawal symptoms have been reported for many classes of psychotropic drugs. Technically, withdrawal should be considered as a side effect. More abruptly, a drug is stopped. Shorter is the elimination half-life. More is the withdrawal. So these are the drug factors which decide if withdrawal might occur. It can result from missed doses, and gradual tapering of medication after prolonged use is recommended. So if you want to stop the medication, you have to gradually decrease the doses, otherwise patient will go into withdrawal. In some cases, such as barbiturates, withdrawal can also be fatal, so that is why knowing about this is important. Benzodiazepines commonly produce more immediate and intense withdrawal symptoms like anxiety or seizures can also occur. More frequent and severe withdrawal is seen with paroxetine. Fluoxetine may be associated with discontinuation symptoms, but they are delayed and attenuated. Now, what are the various types of psychotropic drug classes? Okay, so coming to the first, that is antidepressants. In antidepressants, we have the most commonly used ones, which are SSRIs. They are selective serotonin reuptake inhibitors. In this, the commonly used ones are fluoxetine, paroxetine, escitalopram, and sertraline. Their mechanism of action is that they inhibit the reuptake of specifically serotonin by binding to a receptor called as SERT. SERT is the serotonin reuptake in a transporter. So they inhibit the reuptake of serotonin and hence they increase the serotonin inside the brain. Next, we have SNRIs, so serotonin norepinephrine reuptake inhibitors. These can be duloxetine, venlafaxine, desvenlafaxine, milnacipran, levomilnacipran. So their mechanism of action is inhibiting reuptake of serotonin and noradrenaline both. So now inside the brain we have increase in serotonin and norepinephrine. So they act on SERT and NAT. So SERT is your serotonin receptor and NAT is your noradrenaline receptor. Now coming to tricyclic antidepressants. So TCAs are your amitriptyline, nortriptyline, very commonly used. Imipramine, desipramine, clomipramine are also used. They inhibit reuptake of both serotonin and norepinephrine by acting on SERT and NAT, but they act on other receptors also like histamine receptors and they also have anticholinergic properties. Then we have MAO inhibitors. We don't use them now because they have fatal cheese reaction. So phenylzine, salicyline, they are very rarely used, and if we have to use, reversible MAO inhibitors are preferred. Then we have some atypical antidepressants like bupropion, which acts by inhibiting the dopamine reuptake inhibitor. So this will increase dopamine in the brain. Then we have mirtazapine, and mirtazapine acts by it acts on the serotonin receptor. It's a serotonin receptor modulator and reuptake inhibitor. It also acts on alpha 1 and H1. So, looking at the diagram, you can see whatever I had described. This is a neuron. So, in a neuron, this is one neuron, this is the second neuron. In this, we have a cleft. So, reuptake inhibitor is this. So, when you inhibit the reuptake, serotonin increases inside this. Okay. So this is the diagrammatic representation of antidepressant mechanism. Now coming to the side effects of antidepressant medication. Side effects more commonly found are dry mouth, urinary retention, blurred vision, constipation, abdominal pain, delayed ejaculation, agitation, and anxiety. Next comes our antipsychotics. So in antipsychotics, we have first generation. They are known as typical antipsychotics. They are haloperidol, chlorpromazine, it's a long list of medication, but I've highlighted the commonly used ones so that you can remember just a few. In second generation or atypical, we have again clozapine, olanzapine, risperidone. Then we have quetiapine, and again the long list of medication. Third generation, we have aripiprazole. So these are your antipsychotics. Their mechanism of action is that they are dopamine receptor antagonist. So they will block the dopamine receptor and they will decrease the excess activity of dopamine which is occurring inside the brain. So the side effects of antipsychotics are muscle rigidity, significantly slowed movements, involuntary muscle movements and contractures, tremors, akathisia, tardive dyskinesia, neuroleptic malignant syndrome. Then we have some which are specifically seen in a few atypical antipsychotics, that is sedation, dizziness, weight gain, sexual dysfunction, cardiac side effects, hypotension, dry mouth, constipation. Then GI side effects like nausea, vomiting, constipation can also occur. Now, the coming to the third class, that is mood stabilizers. So in mood stabilizers, again we have a very long list. Commonly used ones are valproate, carbamazepine, lamotrigine, oxcarbazepine. So they were used in epilepsy, but we can use them for bipolar depression or bipolar mania also. Then comes lithium. So lithium is a drug which is specifically used as a mood stabilizer. Problem with lithium is narrow therapeutic index. So whenever you are talking about lithium, you have to talk about narrow therapeutic index, and I'll explain what narrow therapeutic index is in this diagram. So for maintenance therapy or for treatment of acute mania, you need blood levels of at least zero point 0.6 to zero point 0.8 or till 1.2. So for treatment, zero point 0.6 to 1.2 should be the therapeutic range. But if the range goes beyond 1.5, it is toxicity. So we have just 0.3 of drug level to cross from therapeutic to toxic. So that is why this is known as a narrow therapeutic index. Common side effects of lithium are dizziness, drowsiness, tremors, trouble walking, dry mouth, increased thirst or urination, nausea, vomiting, loss of appetite, rash or blurred vision. And coming to toxicity. So toxicity is if it is less than 1.5, you can see tremors, rigidity, GI side effects, polyuria, polydipsia, agitation, confusion and delirium. But when the drug level goes to 1.5 to 2.5, then you'll get coarse tremors, you'll get muscle weakness, hyperreflexia, slurred speech, blurred vision, ataxia, sedation, lethargy, and hyperthermia. In severe toxicity, when the toxicity goes beyond 2.5, then you'll again get coarse tremors, but you'll get delirium, stupor, clonus, seizures. You can get QTC prolongation on ECG, renal failure, respiratory complications, coma, and death can also occur. So how will you manage lithium toxicity? At lower levels from 1.2 to 1.5, you can just give IV saline. You can give oral sodium polystyrene sulfonate. Hemodialysis is rarely needed at these levels. It is indicated if a patient has end-stage renal disease or some renal pathology, but not needed at less than 2.5. But more than 2.5, we have to consider hemodialysis also along with the other treatments. And if it is more than 4, then hemodialysis is the only treatment. There is no other possibility. So adverse effects of other commonly described mood stabilizers should also be known. So carbamazepine can cause nausea, dizziness, unsteadiness, drowsiness, dry mouth, constipation. Sometimes serious side effects of carbamazepine can also occur like worsening of depression, suicidal thoughts, severe dizziness, swelling, itching or trouble breathing. Coming to lamotrigine, you can have backache, chest pain, stomach cramps, inflammation. Serious side effects are Steven-Johnson syndrome. So it is a rash and it is a life-threatening rash which can occur. In valproate again, you can get GI side effects like nausea, vomiting. CNS side effects like dizziness, drowsiness, headache, blurred vision can be there. Hair loss again is very commonly seen. A lot of patients will stop medications because they are having so much of hair loss. Changes in appetite, weight gain can also occur. In serious side effects, we have drowsiness, confusion, easy bruising. Sometimes a worsening of seizures can occur, flu-like symptoms. Fulminant hepatic failure can occur. So, patients who have a compromised liver function should not be given this medication. Then coming to anxiolytics, this is the fourth class of medication. Anxiolytics at higher doses act as sedatives and hypnotics. So same drug at lower doses will decrease anxiety and at higher doses will cause sleep. So, benzodiazepines are the main class. All benzodiazepines are thought to work by enhancing the inhibitory action of GABA. GABA is a neurotransmitter. And long acting are your diazepam, flunitrazepam, and medium acting are your lorazepam, alprazolam, short acting are midazolam, oxazepam. The antagonist is flumazenil, which is given in toxic levels or toxic situations. Side effects are again dizziness, drowsiness, confusion, nervousness. Sometimes inappropriate behavior and mood swing can also occur. There is risk for addiction. So patient can get addicted on these drugs. It causes respiratory depression, so patient will have breathing difficulty, trouble thinking and focusing, frequent memory loss. This can also cause liver failure and damage to a lot of tissues. De-addiction uh, again is done by psychiatry, and a lot of drugs are there which we use in de-addiction, like thiamine. So thiamine is given in alcohol de-addiction. Baclofen is a muscle relaxant, but it also acts as anti-craving. Another anti-craving drug is acamprosate, which inhibits the GABA B receptor. Disulfiram is an aversive agent. So this is an aldehyde dehydrogenase inhibitor. Opioid agonists like buprenorphine, tramadol, tapentadol is given as substitution therapy in opioid addiction patients. Clonidine and guanfacine, these are your alpha 2 receptor agonist. These are also given in addiction, especially if the patient has agitation or withdrawal symptoms. It works very well. Then we have some opioid antagonists like naltrexone and naloxone. These are blocking agents. Dopamine receptor inhibitor like bupropion can act as anti-craving for tobacco. Then drug treatment for dementia and Alzheimer's. So we have cholinesterase inhibitors like donepezil, rivastigmine, galantamine, and tacrine. We have NMDA receptor antagonists like memantine. Then we have phosphodiesterase inhibitors like sildenafil and tadalafil for erectile dysfunction. Sympathomimetic agents like methylphenidate, dextromethamphetamine, and other stimulants can be given for ADHD treatment. To counteract the psychotropic induced side effects, we can use some drugs like antihistaminics are used for extrapyramidal side effect dystonia and akathisia. So these are your diphenhydramine, cyproheptadine, and promethazine. Sometimes anticholinergics can also be given for extrapyramidal side effects dystonia and akathisia like triaxiphenidil and procyclidine. Postsynaptic muscle relaxants like dantrolene can be used for neuroleptic malignant syndrome. Bromocriptine is also used in neuroleptic malignant syndrome and hyperprolactinemia. It is a dopamine agonist. So we finished with drugs. Now coming to brain stimulation methods. So we use electric currents, or we change the magnetic fields and then use the electric current which is produced. The brain stimulation methods are cranial electrical stimulation, ECT, the electroconvulsive therapy, transcranial direct current stimulation. It is called as direct current polarization, transcranial magnetic stimulation, and some surgical techniques like deep brain stimulation and vagal nerve stimulation can also be used. So ECT, it is known as shock therapy. It was a standard psychiatric treatment in which electricity is delivered through the scalp to induce a seizure. So ECT is the oldest somatic treatment for many psychiatric disorders like depression, bipolar, schizophrenia, and catatonia. Now only modified ECT is used, that is, we use anesthesia also. So without anesthesia, we don't give ECT these days. Contraindicated in minor and psychiatric emergencies as per the MHCA 2017. So here you can see the ECT machine. We uh, attach the electrodes here, and then the current is formed and a seizure is seen here. Then we have cranial electrical stimulation. It was originally called electrosleep, and as the name suggests, it was used to treat insomnia. This treatment uses much lower levels of alternating current than the ECT and is the subconvulsive. Transcranial magnetic stimulation, as you can see in the picture here, it was initially used in neurology for nerve conduction studies, but quickly caught the attention of psychiatrists eager to explore other less invasive alternatives to ECT. Then we have deep brain stimulation and vagus nerve stimulation. Both were approved by the FDA in 1997 with indications for treatment of neurological conditions. Vagal nerve stimulation was originally approved as adjuvant therapy in reducing the frequency of epileptic seizures, while deep brain stimulation was initially approved for treatment of essential tremor and Parkinson's tremor. At present, indication for vagal nerve stimulation include adult treatment of treatment-resistant depression and epilepsy. So, in this diagram, you can see deep brain stimulation, and this is your vagal nerve stimulation. So, psychosurgeries. Definition in prehistoric times was likely the earliest surgery for psychopathology. A review of more than 10,000 prefrontal lobotomies concluded that while 70% showed improvement, only and adverse effects included 6% mortality, seizures in 1%, and disinhibition in 1.5%. However, with the introduction of chlorpromazine and other medications, this surgery was discontinued later as the limitations of neuroleptics and ECT treatment became known. There was a renewed interest in psychiatric neurosurgeries at a few academic centers. Now, other surgeries which can be used are your subcaudate tracheotomy, which is used in OCD and major depression. Anterior cingulotomy is used in major depression and OCD. Limbic leucotomy is used on major depression, OCD, and other anxiety disorders. Anterior capsulotomy is used for OCD, but it can also be used in major depression and other anxiety disorders. And then some vaccines are also being developed in psychiatric treatments, but they are all under research, so they haven't been developed as yet. So to summarize, whenever we want to treat a patient, we should follow general guidelines of psychopharmacology. We should introspect in case there is a treatment failure, what is the diagnosis or what is the alternate diagnosis. Consider dependence potential in case of tolerance. Various classification of drugs are used and are available. You should keep in mind other related drugs also. Brain stimulation methods and psychosurgeries are also available. biological therapy options if drugs are not working or are not available. Vaccines are being developed and are probably the future of psychiatric treatment. With this, I would like to conclude the lecture. Thank you so much for listening.